Okay. So hi, I'm Matt Corriere. I'm a vascular surgeon at University of Michigan, and we have an interview set up with Dr. Todd Berland today. And as background, in sorting out through the Vascular and Endovascular Surgery Society, we initially sent Dr. Berland a list of questions to have him answer because he's sort of in the eye of the COVID hurricane right now, while a lot of other places are trying to anticipate what might change in the coming weeks. And when he gave us the written answers, there was so much interest in the additional questions that could be asked that we were asked to set up this video interview. So Todd, thanks for making the time.
Yeah, no, thanks. And for the people that will be watching this, obviously our relationship is through that of Vascular Endovascular Surgery Society, through the VESS. And Matt, I want to thank you for all your contributions and hard work and leading the society in a great direction, especially during this tough time right now.
And as you might be able to see, I'm doing this from home. I'm in my off week. We're doing the Lombardi model of coverage, and Todd, it looks like you're at work in your office. So with that as a segue, question one: what does your current work week look like? Where do you go? What do you do? And how has it changed?
Yeah, so it's definitely interesting. Pre-COVID, before the tidal wave hit us, we were sitting around kind of bored, covering vascular emergencies that were infrequent. We'd finish up our manuscripts that we were trying to wrap up, and we were kind of waiting for things to get busy, and then they got busy. And what's happened now is that I've been fully deployed onto the medical service, and then at the end of the week, it'll actually be the ICU service, working 12-hour shifts, just taking care of COVID patients. I'm doing no vascular. I have no vascular call. I'm not seeing any of my vascular patients. We are rotating in and out of this COVID duty. So some of my partners are holding back to take care of the vascular emergencies at each of the hospitals that we cover. And if any of my patients call in, they're dealt with by my partners, so I can stay completely focused on the COVID issue.
What does it look like when a vascular emergency shows up and maybe there's no blood in the blood bank, or maybe there's no OR availability? How are you handling what to do with those people?
Yeah, it's a great question. And it really depends on whether or not they're COVID positive or negative, and what's their real emergency. We've had about 4 or 5 cold extremities, arterial thromboses in patients with no other risk factor other than the fact they're COVID positive and their D-dimers are out the roof. So we are seeing them come in these hypercoagulable states. One of the patients died very quickly, so we didn't address the leg. The others we would heparinize, and they did okay. So there were no interventions. That being said, as we speak, one of my partners is doing a bypass on a COVID negative patient for severe rest pain and tissue loss. But we are really only limiting vascular surgery procedures to the uttermost critical issues: limb ischemia and ruptured aneurysms. That's it.
And that's a great segue into, you mentioned the D-dimer being positive. What are some of the things that vascular surgeons who haven't taken care of these patients yet, what are some unique things to taking care of these patients who are COVID positive that you know now that you wish you'd known a month ago?
Sure. Well, first of all, we order these panels of markers that we never really look at as a vascular surgeon. D-dimer is one of the ones we're more comfortable with, but we're ordering CRPs, ferritin levels, procalcitonin levels, lactate dehydrogenase, CRPs, and we're trending these. And what we're seeing are the patients that have the highest D-dimer and highest inflammatory markers are the ones that do the worst. So what we do, and those patients are the candidates for these newer biological drugs. We call it TOSI. Tosizilimab is a drug that we're giving. It's an IL-6 inhibitor to patients that come in, try to prevent this cytokine storm that you often see before patients succumb to the disease. What we're trying to hash out is, what is the D-dimer level that requires anticoagulation? And there's no direct correlation between D-dimer number, and you should anticoagulate. We're looking at that. We've set up an emergency IRB database, and we're trying to sort out what is that number. And we think it may be a combination of more than just D-dimer, but probably something like the other inflammatory markers, possibly even adding creatinine there. We start to see the creatinine go up on these patients with no history of renal failure. They start to go up when the D-dimers are elevated, potentially suggesting some microvascular phenomenon that's going on here.
And along those lines, have you adjusted your criteria for diagnostic testing and, criteria, say, to anticoagulate a patient versus get a duplex on their legs? I know at my institution, we've been concerned about the exposure risk both to the technologists and the rest of the hospital, doing a lot of screening for lower extremity DVT, for example, in the setting of these positive D-dimers.
No, I completely agree. And it's amazing. This phenomenon has really decreased the number of duplex that are ordered on patients. And we have a much higher positive rate on the duplexes that are ordered. But I agree. I think that it's, if it looks like a DVT, you've got unilateral leg swelling, the D-dimer is very high. We know these patients are potentially succumbing to a vascular thrombotic phenomenon. We are just giving heparin. If we're not sure, we'll get a duplex. But I would say our duplex rate, we are probably scanning 10 to 20% of the amount of patients we would normally scan in our hospital system right now, for the reasons that you mentioned. We don't want to expose the entire teams to all these COVID positive patients.
So I don't know where you're at in terms of whether you're at your apex yet or not, but as you think about the other side of the mountain, so to speak, has your group started organizing a plan of what to do with this backlog of elective cases and diagnostic tests that have stacked up? And you anticipate having to work, in a different shift after the COVID has died down just to dig out of the hole we're in here?
Patients are being put on the back burner. We have a short list of patients and we're kind of organizing them in acuity, like the 7-centimeter aneurysms that are asymptomatic that we want to get to. We would have normally done those within a week or two. Now these are sitting on the back burner. This is going to have a long, drawn out effect. I've got family members, friends. I know other people that have cancer diagnoses. They're not getting cancer operations right now. Similarly, we're not doing the elective vascular procedures. So we are keeping a short list that we'll get to when we can see the light at the end of the tunnel. Right now, we don't see that light. I don't know when we will. I don't think the light will just turn on. It might fade on slowly. We certainly worry that any kind of lifting of the social distancing could cause a second wave to come through, and we just don't have capacity for that. We're at our hospital is well stocked and we're doing well, but I don't want to speak on behalf of all the other New York City hospitals. Bronx and Brooklyn are getting hit really hard. And from what I've heard, they are in a slightly different situation than we're in. We've got a lot of patients that have stepped up to volunteer, a lot of physicians that have stepped up to volunteer. We've got proper PPE in our hospital. And so I don't feel unsafe or overworked. I'm doing 12-hour shifts as a hospitalist right now, not my career choice, but I don't have the option to do vascular surgery right now, and I feel like I'm just doing this for the cause. I think you would do the same thing once you guys are in that predicament too.
So shifting gears a little bit, how are you dealing with the physical and mental stress, both of being displaced into an unfamiliar work environment and job description, as well as the stress of those patients that are piling up and some of these tough decisions you have to make? Do you have advice for that, or can you share some?
It's tough, and I'm trying to sort it out, and I don't claim to be an expert at this, but I think you're right. Like the mental health part of this and the physical well-being is probably really important. The issues I'm finding are that, number one, you go into a new rotation. It's a bit like being an intern where you're meeting a new group of folks. It's a new system. You're ordering labs you haven't ordered. The only difference is your career doesn't depend on it. You're not gunning for a residency or a fellowship. So I don't feel that kind of pressure to impress. I'm doing what I feel like I need to do. I'm ordering the labs I need to order, and I'm getting that done. When I'm done with the 12-hour shift, I'm trying to do some exercises in my house. I haven't gone out to run yet, but I would like to try to maybe throw a mask on and go run in Central Park. The hardest part has been the food. I'm not living with my family right now. I'm living alone. Nobody to do the grocery shopping for me. And when I get off a long shift and go to the grocery store, the line's 2 blocks long because everyone's social distancing, and I don't want to spend the hours to wait in the line. There was an article, I think in the New York Times, saying healthcare workers get to skip the line. When I went to the grocery store last night with my hospital badge saying, "Hey, is this true? I'm a doctor." They said, "Get to the back of the line." So I have not seen any reprieve from that standpoint. I'm trying to get to the store to get some healthy foods going, but that's one of the most difficult parts for me, is to try to stay healthy and eat healthy, because like you mentioned, I think that's the most important part of getting through this.
Was it a hard decision to kind of break off and live separate from your family during this time? I think that's a decision that a number of people are considering and are not sure what the right call is in terms of mental health versus worry about infecting your family.
Right. Well, I feel very lucky to be able to have a house about an hour outside the city where my wife and two kids, 5 and 8 years old, could do the homeschooling. She could do her work from home, and our nanny is actually living with them. So I feel like I'm in a great situation and would rather them be out there for now. Although we know kids don't get infected by this, I would just worry about my wife and our nanny getting infected. So I like the fact that they're away. It sucks not seeing your kids. It's terrible not seeing your kids. What I do every night, though, is I go to sleep with my kids by FaceTime. We put an iPad next to the pillow. We connect on FaceTime, and I lay with them, and I'll tell them a story, and we'll kind of hang out until they're sleeping. And that's become our routine.
Wow. So what have we not touched on? What other advice would you give vascular surgeons who are kind of anticipating the surge in their own hospital or region and haven't had it yet? And are trying to think of how to prepare?
I think have a plan for where you're going to go. We didn't realize how this was going to work from the standpoint of patients keep coming in. When they get intubated, which there's a high rate of patients that need this high level of critical care, you notice the hospital just kind of grows as a big ICU hospital, and you need more and more doctors to step up and manage the vents on these patients and manage the critical care nature. I think that vascular surgeons, along with some of the other surgical subspecialties, are well suited to manage these patients. So I think that we're kind of moving more towards that ICU role here as the need has grown. Initially, the capacity from the ICU standpoint was stable, and we did not anticipate the hospital being 50% or more ICU, which is where we're at right now. Are you going to be the line team? Are you going to, are you going to deal with help with intubations? These are all things that need to be worked out. And at the same time, I think it's helpful to work out your call schedule. While some will have to stay back and manage those vascular emergencies that seem to be far and few between, but they still are coming through the door, you can't have everybody redeployed at the same time. So you need to have a plan for who's going to stay back on call, who's going to rotate on and off, and who might get sick and fall to COVID and come off the call schedule altogether. So you've got to have a little bit of redundancy in the system.
Are you trying to partition your group so that someone is always kind of on the bench and not in the hospital in case someone does get sick? Or, most vascular groups are fairly small and you can kind of dwindle quickly with a couple sick people.
Right, exactly. We've got 8 or 9 folks, and so we've kind of got groups of 3, and we're doing 2-week blocks at a time. So 2 weeks of us, a third of us are dealing with COVID patients for 2 weeks, while the rest stay back and cover the emergencies in the hospitals, and that gives us the redundancy. You could get sick just as likely taking care of office patients or doing the emergencies or just walking around town going to the grocery store. So yes, I may be at higher risk taking care of the COVID patients, but anybody could get sick, and that's why we need to have some redundancy in the system. But at any given time, we're doing a third of us with direct COVID care.
Well, I sure appreciate you making the time for this interview, and I think it's super valuable for people to be able to learn from your experience, which is coming in first and in a volume that no one else in the U.S. has seen. And thanks so much for giving us this valuable information. And we'll see if we can get this distributed through the VESS YouTube channel so that others can take advantage of it.
Great. Thanks so much, Beth. Recommendations to everyone else: wash your hands, stay safe, try to flatten the curve.
All right. Great closing comments. Take care.